Welcome, everyone. It's so great to see so many people interested in our inaugural launch of our webinar series and our topic, Menopause and Midlife Health. I'm pleased to announce this new initiative. It is a joint webinar series sponsored by the Uniformed Services University's Military Women's Health Research Program and the National Institutes of Health Office of Research on Women's Health. This series will focus on crucial research topics within both women's health and military women's health. Today is the launch of our first webinar focused on menopause and midlife health. Following this inaugural session, these webinars will be held monthly on the second Thursday of each month at 3 p.m. Eastern Time. So mark your calendars. Each webinar is going to highlight different topics and speakers relevant to military and women's health. Next month, the July 10th webinar is going to be focused on violence against women and trauma. I'm Dr. Lynette Hamlin. The Uniformed Services University Military Women's Health Research Program was established in 2017, and in 2023, I was named its inaugural director. The mission of our research program is to promote, manage, and coordinate the research that will improve the health of military women through interdisciplinary collaboration and policy recommendations. Fun fact, did you know that the number of women in the military represent a force more than the size of the total United States Navy? Women make up nearly 20% of the total military force and are a rapidly growing segment of recruits. Our goal through these webinars is to bring together leading experts from the Department of Defense and the National Institutes of Health to share valuable insights and research findings. We're committed to highlighting crucial areas of study and fostering collaboration in this important field of women's health. As we get started today, please note that the chat has been disabled. Please enter your questions in the Q&A section on Teams. We recognize not everyone may have access to the Q&A. We will have limited time for questions at the end of the two presentations. If your question does not get addressed, we encourage you to reach out to the presenters after the webinar. You can also contact my team, Christy Kennedy, and I'm not sure her email's on the screen, Kenady.ctr@usuhs.edu for additional information. Following this webinar, we will do our best to share a copy of the presentation recording while it's available. Before I introduce our first speaker, I'd like to make two announcements. Our Military Women's Health Research Symposium Enduring Continuing Education activity is available for CEUs through AMSIS, and the QR code will be found on one of the slides in this presentation. There we go. Thank you. Second, our program has created a forward-facing military women's health research database, which can be found simply by Googling Military Women's Health Research Database. It contains all of our grants, presentations, etc. on military women's health research. Now for the exciting part. Next, I have the distinct pleasure of introducing our first speaker for this webinar. Ms. Miranda Janvrin is a research associate at the Henry M. Jackson Foundation for the Advancement of Military Medicine in support of the Center for Health Services Research at the Uniformed Services University. She is currently a public health doctoral student and received her master's in public health from Yale University in 2019. In her current role, Ms. Janvrin has published several studies on women's health topics and manages the Women's Health Portfolio for the Center for Health Services Research. Her presentation today is going to be the experiences of midlife active duty service women accessing treatment for menopausal symptoms, a pilot study. Welcome, Ms. Janvrin.
Thank you so much, Dr. Hamlin. Good afternoon. I'm Miranda, and today I'm here on behalf of my team to share with you our work, the experiences of midlife active duty servicewomen accessing treatment for menopausal symptoms. It is a pilot study in preparation for a larger qualitative study of active duty servicewomen experiencing menopausal symptoms. Next slide, please. Disclaimer, these views are my own and are not representative of any of these organizations. This work was funded and it was reviewed and found to be exempt by the Uniformed Services University, IRB. Next slide, please. First, let's start with a brief background. Next slide, please. Here on the left, I have a brief definition of menopause. It says menopause describes the stage of a woman's life when her menstrual periods stop permanently and she can no longer get pregnant. Specifically, a woman is considered menopausal when she is has not experienced a menstrual period for the previous 12 months. This generally occurs around age 52. Prior to this, a woman may experience perimenopause, which is when she is still experiencing some menstrual periods, but also starts experiencing menopausal symptoms. This can begin as early as a woman's mid-30s. The transition into menopause can be a difficult phase of life for many women, especially when they're still balancing their advancing career and taking care of their family. Vasomotor symptoms, these are hot flashes and night sweats, generally considered to be the cardinal symptoms of menopause, start to occur during this time period and can have a negative impact on both a woman's quality of life, mental health, and workplace productivity. About 60 to 80% of women will experience vasomotor symptoms at some point during their transition. Next slide, please. Unfortunately, our active duty servicewomen are not immune to this and in fact experience some unique challenges due to their service. Active duty servicewomen are required to meet height and weight standards as well as physical fitness standards and have to maintain a high level of mental acuity for their assignment. The number of active duty servicewomen in the military population is growing and has been increasing over time. It was 17.7% in 2023. So this is a growing population. Next slide, please. Hormone therapy is considered the first-line treatment for treating vasomotor symptoms and typically consists of either an estrogen alone or in combination with a progestogen. Hormone therapy is considered to be relatively safe for those under age 60 or within the last 10 years before the final menstrual period. Earlier this year, our team published a paper on menopausal hormone therapy use among active duty servicewomen in the Menopause Journal. And we found that the prevalence of hormone therapy use among active duty servicewomen between the ages of 45 and 64 was 9.5%. This is more than double the amount in the civilian population and slightly less than in the veteran population. While this sounds great, it is still less than those who are likely eligible, which would be about 35% of this population. And this is despite active duty servicewomen having universal access to healthcare. So we wanted to understand why these active duty servicewomen who might be eligible for hormone therapy were not taking advantage of it. Next slide, please. Which brings us to this study. In order to understand that, we had to understand the lived experiences of active duty servicewomen experiencing menopausal symptoms so that we could identify any barriers they were experiencing in accessing care and any areas for improvement in policy and education as well. Next slide, please. So how did we do this? Next slide, please. We did this by conducting a qualitative key informant interview study. We chose key informant interviews because we wanted to gain in-depth insights into the lived experiences of active duty servicewomen experiencing menopausal symptoms, and key informant interviews is a great way to get at that. We utilized Google Meet to conduct our interviews, and we used a semi-structured interview guide that we adapted from a study published last year by Shepard and colleagues. We adapted the interview guide to include some questions that pertain specifically to active duty servicewomen. Questions asked, we have a couple sample questions on the right, but overall questions asked included current symptoms, any challenges faced due to their symptoms, what, if any, kinds of treatment they were receiving, and what expectations they had of menopause before starting the transition. We conducted interviews between mid-December of last year and end of January of this year, and our sample size was determined by thematic saturation. This means that we had reached the point in data collection where no new themes or patterns were emerging from the data. And we received immense engagement. The level of engagement that we received from servicewomen was surprising. I remember we began our recruitment efforts on a Friday in December, right before the holidays, and by Monday, my inbox was filled with potential participants. We then conducted analysis of our results using in vivo and open coding techniques. Next slide, please. Here are our inclusion and exclusion criteria. We included participants who were female, active duty, between the ages of 40 and 60, and in the Air Force, Army, Marine Corps, Navy, or Space Force. And we excluded anyone who was male, reservists, veterans, or retirees because we were specifically looking at barriers within the military health system, those below age 40 or above age 60, and those in the Coast Guard or Public Health Service because sometimes there are differences in access to care between those services and the other services. Next slide, please. So what did we find? Next slide, please. We conducted a total of 38 interviews with active duty servicewomen who ranged in age from 40 to 56, with an average age of around 46 years. Across service branches, we saw the most Air Force participants, but there was also great engagement from both the Army and the Navy. And our participants were majority white, married, and between 04 and 06 rank. Next slide, please. We asked our participants what symptoms they had been experiencing, and we found that 74% of our participants had experienced hot flashes, 79% experienced difficulty concentrating, and 82% experienced weight gain. We also asked our participants about difficulties sleeping and fatigue, any anxiety or depressive symptoms, any joint or muscle pains, and any issues with sexual functioning. So this pattern continued across all of those symptoms, with a large majority of our participants having experienced these symptoms at some point during their transition. Next slide, please. We also asked our participants what, if any, treatments or symptom management techniques they were using. The two most commonly discussed were hormone therapy, which we talked about earlier, and black cohosh, which is a menopausal supplement. Participants also discussed DHEA, another supplement, testosterone, other menopause supplements, exercise and intentional weight loss, mindfulness, meditation and prayer, and cooling techniques. Next slide, please. When we conducted our thematic analysis, we found 8 key themes, and these included perceived dismissal by providers and lack of information, care access and civilian alternatives, continuity of care disruptions, change in identity and emotional impact, risks to career advancement, challenges in performance and preparedness, leadership pressures and gender expectations, and resilience. And I'll go into each of these themes in more detail across the next slides. Next slide, please. For each of our key themes we're going to discuss, we have the title, a brief description, and a representative quote. So for the first theme, perceived dismissal by providers and lack of information. Most of our participants felt dismissed or misunderstood by their providers and felt their providers were unable to give them adequate information about perimenopause, menopause, and any sort of treatment or care that they could receive. And this led to avoidance of care, frustrations, and delayed care, with participant 38 saying that she felt that she needed to fight for her health care, which shouldn't happen in a universal healthcare system. The second key theme was care access and civilian alternatives. This encompassed all of the challenges that servicewomen experienced when trying to get access to menopause care. which included difficulties getting an appointment, meeting with providers who lacked training and knowledge of menopause, which led to misdiagnosis, inadequate care, and some inappropriate referrals, especially to behavioral health. This led some of our participants to seek care outside of the military health system, with participant 6 saying how she tried to discuss it with military health system providers, but was completely blown off and because of that felt forced to seek outside care. The third theme was continuity of care disruptions. Our service members experience frequent moves due to PCSs or deployments and often have their primary care managers change, which can cause disruptions and in provider relationships. Each time the service member feels like they have to completely start from scratch, going over their symptoms and their experience, and it can be really frustrating as well as lead to delays and fragmented treatment. With participant 10 saying how she didn't have the same provider more than one time and had to keep rehashing her past experiences with other providers and reconvincing them of her need for care for her symptoms. Next slide, please. The fourth theme was change in identity and emotional impact. Menopause can be an emotionally challenging time for all women, and our participants experienced declines in confidence and self-esteem, especially in professional settings. Some of them also experienced increased empathy for their peers and predecessors who were either currently dealing with symptoms or had dealt with symptoms before and they hadn't realized it, as well as adoption of more flexible expectations for themselves. And some experienced personal disappointment, such as participant 1, who experienced menopause very early and had to come to the realization that despite wanting to, she wouldn't be able to have another child. The next key theme was risks to career advancement. Some of our service members felt that their experience may have impacted their promotion and career progression. The unexplained weight gain due to menopause affected their fitness results, their promotion eligibility, and their confidence, with participant 35 expressing how she felt that her weight gain essentially guaranteed that she would never promote to colonel. The next key theme was challenges in performance and preparedness. Many of our participants described themselves as being high performers and high achievers, but the fatigue, brain fog, and difficulty concentrating made performance difficult for them and made them start to question whether or not they should consider retirement. Participant 13 said that she felt maybe it was time to retire because she's just not as quick as she used to be. Next slide, please. The next theme was leadership pressures and gender. Gendered biases in this male-dominated field of the military contributed to additional emotional burden for our participants, and they described not wanting to be seen as overly emotional or an emotional woman. They also were uncertain of what initiatives were in place to support them, especially in leadership roles, as participant 17 mentions. The final theme was resilience. Despite all of the challenges that these servicewomen face due to their menopausal symptoms, they displayed resilience and dedication to the overall mission, with participant 18 saying that despite her challenges, she still truly loves her job. Next slide, please. Our participants made 4 overarching recommendations. The first being access to menopause-specific healthcare. Participant 35 envisioned this as ideally having a menopause-specific clinic for active duty servicewomen. There is currently a virtual telehealth menopause clinic for active duty servicewomen at Walter Reed, but it's currently very small. And in order to serve the entire population that might need access, it would need to be expanded. The next recommendation was enhanced provider education. A lot of the providers that our participants saw did not have extensive knowledge of menopause, perimenopause, and their symptoms and treatment. Specifically, participant 36 noted that when we asked her about what symptoms she had experienced, we mentioned some symptoms that she was not aware were associated with menopause at all, and it would have been great if that information had come from her medical provider. The next recommendation was incorporation of menopause into the periodic health assessment. If you're not familiar, this is a mandatory annual evaluation for active duty service members, and it's used to assess their medical readiness. It's a comprehensive process that includes a self-reported health assessment, a medical record review, a mental health assessment, and a face-to-face consultation with a certified provider. So the participants felt that this would be a good opportunity for menopausal symptoms to be discussed and flagged, specifically to prepare women for the next steps when they're going through perimenopause, as participant 13 mentioned. The last recommendation was a reevaluation of fitness and weight standards. All active duty servicewomen are subject to fitness and weight standards, and there's currently no considerations for women going through menopause. This can lead to additional stress for these women, as described by participant 15. Next slide, please. So let's look at our findings in context. Next slide, please. Our findings aligned with studies of women in both the UK Armed Forces and in the civilian population. Our findings demonstrate a need for increased access to menopause-specific care and treatment in order to keep our servicewomen performing at their peak as long as possible. Our findings also demonstrate a clear need for enhanced provider knowledge of menopause symptoms and treatment, and more information about perimenopause as well. Active duty servicewomen should be able to go to their provider in order to get information on menopause and perimenopause as well as treatment, and shouldn't have to go to TikTok and Instagram to get access to their health care. While it's great that participant 6 is taking a proactive charge of their health care, there's a lot of misinformation on the internet, as we all know, and it's best if she gets evidence-based current information from her provider in the military health system. Next slide, please. To conclude, next slide, please. This study was the first study to capture midlife servicewomen's lived experience going through menopause and experiencing symptoms. Untreated menopause symptoms are all-encompassing and impacts a servicewoman's career, family, and mission readiness. There are current gaps in education, clinical care, and provider awareness. Our team has a couple recommendations, which include increasing access to care for active duty servicewomen through expansion of the telehealth menopause clinic that I mentioned previously, and also inclusion of perimenopause and menopause-related content in the annual periodic health assessment for active duty service members. I wanted to end with these quotes on the left here. From all of our participants, the consensus was that they hoped that by participating in our study and sharing their experiences with us, they would be able to help the next generation of midlife servicewomen. Personally, I was just blown away by the level of engagement and support that we received throughout the course of this study, and I want to thank all of our participants and my colleagues for making this work possible. Next slide, please. Thank you all for your time.
Thank you so much, Ms. Jambin. And we are getting applause and thank yous in the Q&A. Keep utilizing that Q&A for questions. We're going to wait and do questions at the end of both presentations. And now I'd like to welcome Dr. Xenia Tigno from the NIH Office of Research on Women's Health to introduce our next speaker. Dr. Tigno.
Yes, good afternoon, everyone, and thank you for attending the seminar series. I'm Xenia Tigno. As Dr. Bondar mentioned, I'm the Associate Director for Careers at the Office of Research on Women's Health, or ORWH, and part of the mission of ORWH, which is directly under the Office of the Director, is the recruitment, retention, and advancement of women in biomedical careers. And this webinar series is just one of the initiatives that we do to improve women's health and women's careers. This afternoon, I am absolutely delighted to introduce Dr. Haydeen Joff, former president of the North American Menopause Society, and currently a PI on one of ORWH's signature programs called the SCORE, or Specialized Centers of Research Excellence on Sex Differences. Dr. Jaffe is the executive director of the Mary Horgan Connors Center for Women's Health at Harvard. And I had the pleasure of meeting her initially as I was the program scientist of the SWAN many years ago. Dr. Jaffe has been a staunch advocate for women's health and is presented to Congress, in fact, during briefings as one of the rock stars of women's health. And she received her undergrad degree from Harvard, her medical degree from Cornell, her master's in epidemiology from the Harvard School of Public Health, and she completed her psychiatry residency and fellowship at the Mass Gen. Dr. Jaffe's research focuses on brain health in midlife women, and recently she received a grant focused on menopause, hormones, and Alzheimer's disease. Please welcome Dr. Haydeen Jaffe. Dr. Jaffe.
Thank you so much for that introduction. It's really a pleasure to be able to speak here, both as a researcher and as a clinician, somebody who's been taking care of women across menopause through healthy midlife menopause and also in the context of breast cancer treatments for a number of years. You'll see I'm going to be talking about sleep and mood and how crucial they are to midlife health. If you can go to the next slide, please. These are my disclosures. I'm a NIH-funded researcher, and the work I'm going to be talking about comes from the work I do in that capacity. Next slide, please. So very briefly, the objectives that I have here today are to understand the course of depressive disorders, which will inevitably bring in sleep disorders, and to characterize female-specific contributors to depression in midlife. I'll also be talking about how this understanding of what causes mood and sleep disorders in midlife, how that informs our treatment strategies as we approach these people in our clinical practice. Next slide, please. So this is my clinical practice, and for those of you who see patients in this stage of life, maybe this is what you perceive as well. Of course, there are gynecologic issues, important ones, and so, menstrual periods, bleeding, weight, as you've heard, those are important. But what I want to say is brain symptoms are really key and central to all the problems that people have in this stage of life, whether it's sleep or mood or hot flashes or fatigue or worries. And I want to make sure that we all understand what causes them, how they are brain-based, they are biologically driven, as well as influenced by people's stress exposures and also their past experience with mood and sleep problems. And that's what we'll be talking about today. So next slide. I think I've highlighted here that these are the core brain symptoms, vasomotor symptoms, VMS, or hot flashes and night sweats. We really group them together in the work we do and see them interchangeably. I'll highlight also that there are two types of mood conditions, or the common mood conditions. One is a milder form called depressive symptoms, not as severe, not as long lasting, but obviously is disruptive. And one is a much more severe and less frequent occurrence, major depression. And the top right, you'll see just generally the hormonal pattern that we see up until the FMP, the final menstrual period, where the estrogen in the body and in the brain, starts to fluctuate in the perimenopause quite widely. So the brain has to adapt to these wide fluctuations. And then in the late perimenopause and into the postmenopause, that's where you start to see this very low level of estrogen, and progesterone follows that phenomena. Next slide, please. So Miranda made an amazing case for how important this is in the military and beyond. There are key reasons why menopause health is so important. And just to generally bring them together, there's well-being, there's function, and then there's, as we think about future health, there's both lifespan implication and health span, that is the proportion of time people live after menopause that is healthy. And this menopause transition is an inflection point of a risk for some emerging conditions, and also an opportunity to really help people get them be as healthy as possible, so that they can have the optimal postmenopausal health span. The well-being and function have important implications for how people function in different roles. So if you go to the next slide, you heard about this in the military, and just to say, there's a movement to really recognize in the workplace and have employers recognize how important being sensitive to menopause health is for their employees. Long time ago, we didn't even think about this. We didn't think about this for pregnant individuals either. Now there's breastfeeding rooms and areas where people can pump and accommodations. And I realize not in all workplaces, but that's really the goal. And I think this is a movement to progress in that way for midlife health and to understand the responsibility and the opportunity to look out for these employees who are so central to the work that we do in our large organizations and small. Next slide. So you heard a little bit about hot flashes. Just to highlight that, hot flashes occur in 80% of women. When you get out to 10 years after the final menstrual period, which is, say, about the age of 60, 62, a third of women still have them. So we think of them as being temporary, and they are indeed the most common during the perimenopause, late perimenopause, and the early postmenopause, but they do tend to occur more persistently in a subpopulation as well. And on average are lasting 7 to 9 years. So that's a long period of time. The other thing about hot flashes, they occur day and night. It's rare that somebody has them in the day and not in the night, or vice versa. So whenever somebody has hot flashes that they are aware of during the day, they're most likely having them at night as well. And then from this figure on the right here, you can see that, and this is from a clinical trial series we did for women with hot flashes. So that was the most common concern they had. But when you start asking people with hot flashes, what are the other concerns you have related to menopause? You can see how common brain symptoms are: sleep, concentration, fatigue, are in terms of their concerns and priorities. Next slide, please. So just to anchor a little bit on depression, we know that depression occurs across the lifespan twice as commonly in women as in men. This has been looked at in multiple cultures, societies over time. And we also know that this difference in risk is mostly during the reproductive years between puberty and menopause, as you can see here on the right. And there's a sort of blip of risk that you see in the menopause transition, where there's an increased susceptibility that we'll be talking about. Next slide. Now, this is a complicated slide, but I want to highlight something really important, is that when we see this, if you look at the pink arrow going down cross-sectionally, somebody in midlife, we start to think, what's going on? What's going on in life? What are the stressors biologically? What are her menopause symptoms? What's happening hormonally? And it's really important to think about that. And at the same time, we also need to think about what's happened in her life leading up to this time. And that's especially important for accumulated risks that people have across their lifespan, accumulated health exposures. And in terms of brain and depression, particularly important to understand that depression, episodes of major depression, tend to be recurrent. Once somebody has one episode, they're likely to have 50% will have a second. Once they have two, 75% will have a third. Once somebody's had three, over 90% will have subsequent ones. So by the time somebody's reached midlife, she's likely to have had depression before. It's unusual to have a first episode of depression in midlife. So we need to ask, if we see somebody in the peri or early post who has depression, what's happened before? Have they had this before? Is this the same? What treatment did they have? Did it work, etc.? Next slide, please. Now, I mentioned the stressors, and Dr. Tigno highlighted that one of the roles I have is I oversee a menopause research program sponsored by the NIH, which we call the ROSA Center in the top left, Reproductive Outcomes of Stress and Aging. And what we're doing in this study, it's a large study with multiple people, is we're trying to understand how stress experiences over the lifespan affect menopause and menopause health. And so I'll be presenting tidbits of that, but just more to come as we continue progress in this work. And to highlight that stress experiences and how can we not be thinking about stress experiences with military women, particularly that community, and how that can contribute to menopause symptoms. Next slide. So I'm not going to get into this in detail, but I want to highlight that there's, as I said, two kinds of depressive conditions that are most common. There's a more severe major depression on the left and the milder depressive symptoms on the right. And both occur more commonly at this stage of life. The take-home message here is major depression is most likely a recurrence, somebody who's had it before and susceptible to having again, just like postpartum depression. People have it before, susceptible postpartum. Secondly, the risk factors are more traditional psychiatric risk factors. And then in contrast, when we look at the depressive symptoms, those are the group milder condition can occur for the first time. People for the first time have mild mood symptoms. And those are the people, they tend to cluster with all the hot flashes and sleep interruption, which we'll be talking about. Next slide. Oh, thank you. Just to say, let me move on with that one. Next slide. Okay, so some of the work that we do, we looked at, who develops depressive symptoms, this milder condition. And we do this in very rigorously controlled studies where we take healthy individuals and we temporarily put them into menopause in a very controlled, safe way, just for about a month. And what we do is we look at the changes that emerge in their mood and their sleep after they did or didn't develop hot flashes. And basically what we found in the top right here is that the people who developed mild mood symptoms were the ones who had all these kinds of sleep problems, which you see in the top figure. In addition, so basically sleep interruption is bad for mood. And I know people get that, but it's really important, not just sleep onset problems, but sleep interruption. Secondly, even when you put all the sleep problems aside, the nighttime hot flashes are really a problem for people with mood problems. So not daytime hot flashes, but nighttime hot flashes. And it's really important that people get nighttime hot flash control when they have mood problems in this stage of life. Next slide. So I'm going to talk briefly now about treating what they are and treating nighttime sleep problems, which is an interruption problem or fragmentation problem when somebody has hot flashes or night sweats. Next slide. Here I want to highlight on the left that sleep has many different dimensions. It's not just how did you sleep? It's also how many hours, how long were you in bed? Are you sleeping in the day or the night? Or you have trouble falling asleep? Do you wake up repeatedly, et cetera, wake up too early? And the nature in the middle top here, you heard about the SWAN study we have funded by the NIH, looking across multiracial, multi-ethnic communities. And we found that when we asked what is the nature of the sleep problem that occurs in midlife, it's mostly sleep interruption. And that is what you see in the bottom, fragmentation. So instead of going beautifully light sleep, deep sleep, REM, light sleep, deep sleep, REM, there's all this interruption. People wake up, they never get good consolidated sleep, and that's very fatiguing and can interfere with performance and function, as well as, of course, mood. And then top right, just to say, in addition to the hot flashes being the most common driver of sleep problems, we also see the hormone changes being drivers of sleep problems. Next slide. This slide in the middle shows all the many, many drivers of sleep problems, and also that they can co-occur, right? So somebody can have hot flashes that wake them up, but they also can be super stressed, and that makes it harder to fall back asleep. So there are lots of different factors that contribute, and I want to also highlight that on the bottom left, that sleep apnea, which is a respiratory obstructive sleep apnea breathing problem, which we think of as a man's condition. Women catch up to men during this stage of life and across the menopause transition and beyond. So it's a period of under-recognized sleep apnea in women. Next slide. This slide shows, as you can see in the top right in the summary, that we know that when these mild mood changes come and go, They come and they go. People might have them for a few weeks, then they go away, then they come back. They're like, why, why now and not then? And one of the reasons we've been able to show that occurs is that, and this is a figure in the bottom left, is that women go through different stages of hormone patterns during the perimenopause. Sometimes their estrogen is low, sometimes it's bouncing around. And so when we just looked at what's happening in people's hormones over a 2-month period of time with frequent measures, we saw that the people who had this huge variability, erratic variability, that's the kind of 30 to 40, the greatest variability, they had the worst mood changes. So we say, well, why are their mood worse now versus another time? Well, it might be we don't have a daily hormone level, a weekly hormone level, in our typical person. That's only from a research study, but it might be because that's what's happening with them hormonally. Their brain is having to adapt to all these changes. Similarly, on the bottom right, we found that progesterone is actually protective of mood. Now, people sometimes think that progesterone can be bad for mood. But in general, what we found, and we're also looking into it further with other progesterone metabolites, the allopregnanolone metabolite, is that when progesterone is produced by ovulation, that also seemed to be protective of mood at that period of time. Next slide. Now, the cardinal question that is so challenging in clinical practice is that when somebody comes in with depressive symptoms and she happens to be peri or maybe early post, we're trying to figure out, are they related or not? Because as you heard from Miranda, perimenopause happens over a long period of time. On average, 4 years, can be much longer. And it can be very hard to figure out whether it's related or not. Next slide. I'm not going to go through all of this, but I want to highlight that figuring out whether we think that the mood changes are related to perimenopause or not is mostly about asking questions, asking them to provide history about and what's going on and what started when, and whether they're having other symptoms and whether they had depression before, and what else is going on in their life. And those are the most helpful ways to approach somebody and help them understand. And this circle I drew, it's like if the health problem is, as big as a circle, to what extent do I think that the menopause, the perimenopause, hormone driving factors contribute? Is it big? Is it large? Is it most of the circle? Is it small part of the circle? I think that helps you understand what they're dealing with and to take for the problem. And it also helps in our treatment approaches. Next slide. So again, a dense slide. I'm going to highlight just what's in these red boxes, but you heard a little bit about hormone therapy and that is used and FDA approved in this time of life to treat menopause hot flashes. It's not approved by the FDA to treat depression or sleep disturbance. Of course, we've studied it in those populations. But let me just say, firstly, on the left here, that there are studies that show that hormone therapy does have benefit for mood problems, mostly the mild mood problems, and essentially almost always when there's a lot of hot flashes. So we don't know, are we treating the hot flashes and therefore the mood is getting better or not, because it can be hard to disentangle. It's off-label. It's not first-line treatment when the depression is a major depression. It's more severe depression, but it's good for milder symptoms. And on the right, I'll say there are some studies suggesting preventative evidence. It's a complicated story, but essentially we really don't use it for prevention. Next slide. This goes into like stepping back away from hormones and thinking about lots of other treatments that can be used for depression. Again, on the left, the more severe depression, on the right, the milder. And what you see here is essentially that in terms of medication treatments for depression, clinical depression, antidepressants work. We've studied many of them. They work. They're good. There's not a lot of evidence with other kinds of new treatments for depression. But antidepressants work and hormone therapy is not first line. And psychotherapy is important. The psychotherapy can be a really important way of helping people understand what's going on with them, understand if they have a way of expecting what menopause is in their life. And for some people, that's really important. For many people, it's really more biologically driven. The milder symptoms on the right, again, thinking about all the different treatments, this is the time when hormone therapy can be really valuable. Next slide, please. So now treatments for the sleep interruption or sleep fragmentation in women with hot flashes. This is not for people with mood problems, but the sleep problems and hot flashes. Starting on the left, sleep hygiene. We've all heard different parts about it. Don't, drink caffeine before bed, other types of strategies, which mostly focus on sleep onset, right? What do you do in order to help you get to sleep? And I want to say, to highlight in the middle figure here, there's sleep hygiene that's really important for sleep maintenance. And the main thing here is don't look at the clock. Don't know what time it is in the middle of the night. It makes it really hard to fall back asleep. Don't have bright lights, your phone, and don't toss and turn for very long. Those are good strategies for everybody for sleep maintenance problems. On the right, you can see the strategy, a very helpful, effective strategy of CBTI, very effective for helping people sleep. It doesn't treat the hot flashes, but in women with hot flashes, it helps them improve their sleep. Next slide. On the left here from another group I've been a part of with the NIH-funded study called MS Flash. We studied almost 1,000 women for different treatments for hot flashes. And this is the subgroup that had sleep problem. We looked at, what their sleep problems, what was the most effective for their sleep problem. And what you'll see in the pink is that the CBTI was most effective for them. Exercise was effective for them. And then after that, yoga, serotonin agents, the quote unquote antidepressants. This is to treat their sleep problems. I'm treating their sleep problems in people who have hot flashes. Estrogen also had benefit, but it wasn't the most effective treatment. And I'm not going to go into all these treatments on the right, but just to say that there are a number of pharmacologic strategies to treat hot flash related sleep problems. One is treat the hot flash problem, the sleep problem should improve. And the other is you either can't get control of the hot flash, or you say, all right, I know they're hot flashes, but let's focus on the sleep. And there are a number of medication treatments there. I have one or two last slides, and then I will wrap up. Next slide, please. So this is a summary slide of all the different treatments that I went through. And I'm not going to go through all of it here, but you can see the information. And the way I've organized it by row is the hormone treatments, then the what sometimes is called non-hormonal, but they're really brain active medicines that have benefit for psychiatric illness or pain illness or neurologic illness or sleep, and they have benefit. And then the third one is new medications that are coming out, some FDA approved, some in development, which work through a pathway in the brain called neurokinin that are effective for hot flashes and may have some additional benefit. And then behavioral strategies in the bottom row. I've also then organized it by column: mood, hot flashes, hot flash comments, and sleep. And this is a summary of what I presented to you up till now. And then to the next slide. So this is where I hope that you can take home these messages that, fortunately, severe major depression occurs in a subset, but is not nearly as common as the milder condition. So there's a milder condition, there's major depression. The more severe condition, less common, but hugely important, mostly recurrence, definitely needs treatment and wouldn't be treated with hormone therapy as first line, whereas the milder one benefits from the hormone therapy. We don't use hormone therapy to treat mood after menopause when somebody doesn't have hot flashes. So its use is really circumscribed to the perimenopause, hot flashes, and mild mood changes. Antidepressants, quote unquote antidepressants, they work for lots of other things too. Pain, they just work through serotonin pathways. They are effective treatments for mood, whether it's mild or more severe. And there are a lot of different ways to treat sleep problems, but to really highlight how important it is to treat sleep problems, because treating sleep problems is one really important way to help people with their wellness in general, but also to help people who do have mood problems get better control over their mood. And just my last thank you slide to this incredible team. If you can, thank you to say, this is some of our team, sleep, hormone-focused gynecology, endocrinology, brain health, psychiatry, and all the research participants and the staff. And really to say, like, we could not do this work without the NIH funding it. I'm really so grateful for the NIH for saying how important midlife women's health is, and really also to USU and the military for recognizing how critical this is in the population that's plays such central roles in your workforce. So thank you very much. You can take down my slides.
Thank you so much. Christy, you can stop sharing so we can have a nice interactive Q&A, and I'll ask the two presenters to come on camera. And our first person, I'm going to give Cynthia a chance. Cynthia, let me allow your mic. I know you asked so many questions and they were all wonderful. I'm not going to try to pick the best one, so I'll ask you to pick your most burning question to ask. See if you can unmute yourself, Cynthia.
Hello?
Yep, we can hear you.
Hi, thank you for the two wonderful presentations. I'm Cynthia Trachtenberg, Associate Professor at the University of Colorado, and I'm actually a dentist and specialist in periodontics and implant surgery. So I have questions for Miranda and Dr. Hoff. For Dr. Hoffe, in both lectures, there is no distinction between natural and surgical menopause, and we all know that surgical menopause can occur before age 40, and the symptoms not only rely on heats and typical symptoms of the natural menopause. So probably exercise and yoga and non-hormonal therapies don't work. I'm particularly interested in asking Dr. Hoffe why hormone replacement therapy, who has been proven efficient after age 60 and no longer follows the Women Health Initiative in other parts of the world, such as the UK and Australia. I see that the menopausal treatment of mood and depression in women that do no longer have these hormones, and these depressions or mood changes that were not present before menopause. Why hormone replacement therapy is not the first line of therapy instead of relying on strongly pharmaceutical agents?
Yeah.
Thank you.
Yeah, well, thank you. So I'll take your first question, say you're right. I think we were both talking about natural menopause for the most part. That's where there's been the most research. There, in women who have both ovaries out, that's important. Both ovaries have to come out from a surgical menopause for somebody to go into acute menopause, premature menopause. Both ovaries out before the natural menopause or chemotherapy-induced menopause. Or radiation-induced menopause, those population we don't have as much data on. We do, those are breast cancer patients, high-risk ovarian cancer patients, sometimes fibroids, complicated fibroids. And again, both ovaries have to come out. Lots of different scenarios. We do typically use non-hormonal treatments, and they're effective, and they've been studied for hot flashes, and they're effective. So we also use them for sleep problems. So we don't assume that they don't work in them, but we do need much more data. And they do have a lot more symptoms because they acutely go into menopause. And then the other question that you asked about, why don't we use hormones in postmenopause for depression in postmenopausal women without hot flashes? So the data show that it doesn't work in that population. So, it's not effective in that population to initiate hormones to treat the mood problem if they don't have hot flashes. We also typically use it less after age 60 because that is where the risk-benefit decision might change related to heart condition risks and other things. But that's a whole other topic. So I'll leave it at that.
Thank you so much. Okay, our next question comes from Sarah Wright, and she asks, our first speaker, who in the military leadership chain will this study be shared with to include the recommendations that are being made?
We plan on publishing our findings and then sharing it widely within the military health system, especially with Dr. Hamlin's Office of Women's Health Research.
Thank you so much. And then someone asked for Dr. Jaffe, for CBTI, do you recommend the app or individual counseling?
Yeah, so CBTI, this is the cognitive behavioral therapy for insomnia. It's a very specific directed treatment about how to change one's sleep patterns in order to improve insomnia symptoms or insomnia. There are different ways to get access. There are therapists who are trained to do this specifically. There are apps, there are websites. Typically, people can't find somebody to work with them individually because there are not as many people trained in it. If you can, that is wonderful. I would say the apps are really good. The websites are really good. And so I encourage people to try them, to be vigilant, and to really adhere to them and make sure it's personalized to them. You got to put your information in so it tells you what to do about how to change your sleep in response to what's not working for you.
Okay, great. Thank you. And then I think we have another question from Shabina. I guess this could go to either one of you. Menopausal women often suffer from facial hair growth. Is there any research study on this?
You want me to take that or you want to take it, Miranda?
Sure. We did not ask about facial hair growth in our study. That would be something that we would have to look into an additional study.
Yeah, say I think that's true. There actually very little study on hair or skin changes. Many people do describe, hair and skin changes, and you have chronological aging happening. And so trying to disentangle what we know happens just with aging from what's hormonally driven can be tricky. But the facial hair growth or changes in body hair distribution, there are some hormonal basis to some of that. People sometimes see changes in pregnancy, high estrogen states, high progesterone states. It can be seen in high testosterone states. So there are hormonal drivers, but it's not very well understood.
And then one more in the symptom area. Someone also asked, what about cold flashes?
Miranda, do you want to, did you ask about that?
We didn't ask about that specifically, and I don't recall any of our participants mentioning cold flashes, or else maybe we would have reconsidered.
It's so, yeah, it's so interesting when you ask people what do they perceive. So most people notice the heat, but some people notice kind of a shiver and a cold after the heat, or they may not notice the heat. And what we've done in the SWAN study is we lumped them all together, hot flash, cold sweat, I think we called it cold flash, and night sweat, which are nighttime hot flashes together. So we don't actually have as much about one versus the other, but they're really all kind of interrelated because it's a temperature regulation imbalance.
Thank you all so much. So unfortunately, we aren't able to get to all the questions, but we encourage you to reach out to the presenters. And there's a lot of questions about the slides and recording, and we're going to do our best to share the recording of the webinar on our event page or with people that registered. And I want to thank our two speakers. Thank you so much. This was wonderful. Thank you to our planning committee. So much went into this. And if you want to share the slides, Christy, Dr. Tigno, you can close us out.
Yes, I would like to thank everybody for being so engaged and for coming to our inaugural meeting. This has been I guess, 1-year endeavor between ORWH and Dr. Lynette Hamlin's office, and we are so happy that it transpired at this time. We are really both excited. Both our offices are excited about this. So please join us again next month. And Dr. Hamlin mentioned that it will be on July 10, which is a Thursday again. So it's the second Thursday of the month, I think, at 3 p.m. So please join us. And the topic, as you can see here, is violence against women and trauma. So it should remain exciting, So see you then. Thank you.